Basic management principle. You cannot manage what you cannot measure. All right, so let's look at how we can measure cortisol or measure adrenal dysfunction. Now, this is not anything new. This is back in 1983. These data combined with a simple stress-free, non-invasive collection procedure leads us to suggest that salivary cortisol is a more appropriate measure for the clinical assessment of adrenal cortical function than is serum cortisol. And the fact that stress-free, non-invasive collection, because you have to think, if you're measuring morning cortisol through a blood sample, the person has to get there early in the morning, fight the traffic. If I live here in Atlanta, you have to fight the traffic. You're running into the office. You see somebody with a needle, looks like they're shaking, they're new or whatever. That's going to create stress. So it doesn't give you a good idea of how they normally cope with stress, what the normal cortisol curve happens to be. So the fact that it's non-invasive, and actually salivary cortisol levels have become the gold standard. Not quite sure why it hasn't become the gold standard in other steroid hormones, but that's for another lecture. Since salivary cortisol concentrations were shown to reflect the free biologically active fraction in plasma, salivary assay may in selected cases provide results of greater diagnostic significance than plasma total concentrations. And this is in Clinical Endocrinology in 1982. From these results, we conclude that the measurement of saliva cortisol can be used sufficiently to monitor unbound free concentrations in the serum. And remember, with all steroid hormones, the unbound portion is the active portion of the hormone. So it's important that that's what we are measuring. We conclude that salivary cortisol measurements are an excellent index of plasma-free cortisol concentrations. They circumvent the physiological, pathological, and pharmacological changes due to corticosteroid binding globulin alterations and offer a practical approach to assess pituitary adrenal function. And again, what's that last word? It's function. We want to be able to assess function, not to assess disease. Finally, salivary cortisol has been used extensively as a biomarker of stress in research settings, especially in studies examining psychological stress with repeated measurements. So this is in Clinical Endocrinology in 2012. Now, your normal cortisol curve should be based on day-night cycles. It's actually the pineal gland, can detect light and dark, and it sets up a circadian rhythm. And with that circadian rhythm, you have a cortisol curve that should be highest in the morning and then low at night. And that curve can be changed based on day-night cycles. That's why when I live on the East Coast, if you fly out to the West Coast, for the first few days, what is going to happen is that if I wake up at 7 o'clock here, I'm probably going to wake up at 4 o'clock in the morning in California for a few days because my circadian rhythm has not had time to change. And that's why you have jet lag. And so if you stay out in California long enough, this normal curve can change. So if a person is under a condition long enough, the normal cortisol curve can change to accommodate this new situation, this new environment. But the normal cortisol curve should be like this, highest in the morning and lowest at night. Now, here's the key. Not all stress is bad. You need a little bit of stress. If you look along the horizontal line, what's important is how much stress are you under? Because if you're under no stress, then you don't do anything. You just sit around, you're inactive, you're bored. If you think about your kids, this is the example I use. If your kids don't have the stress to get up and go to school, they sleep all day. If they don't have the stress to try to provide for themselves, they'll end up, not wanting to work. So you need to have a little bit of stress. As parents, we create stress in our kids, and as teachers, and even as if you hire a personal trainer because you want them to motivate you. How do they do that? They put you under stress. So this stress curve you see is inactive, is healthy tension, and then motivated, and then focused. But see, there's a very fine line on this peak performance. And that's where people want to be. That's where high achieving people want to be. But that's very close to the line of being fatigued and exhausted and having panic and anxiety and burnout. And so that's how you help people manage their stress, is that if you can measure where they are on this stress horizontal line, you can try and help to keep people at their peak performance and where they don't become fatigued and exhausted and go over into this disease state. So that's what we're going to be talking about, is how do we measure stress and how do we determine where we are in this performance bell-shaped curve. So we want to stay on this side of the bell-shaped curve. Now, we don't want to be on this low end. I mean, when it's time to sleep, we want to sleep. But when we wake up, we want to be alert and we want to be able to function at our optimal level. So this is where we're trying to stay, and we're trying to avoid this side of the curve. We want to, again, stay on that peak, on that medium stress level, and not in that high stress level where it leads to anxiety, disorganization, and burnout. Now, this is a cortisol curve of somebody who is stressed and wired. And just like I told you, if you're under a situation long enough, then your normal cortisol curve will adapt to that situation or that environment. If you're under chronic stress long enough, what happens is when you're under stress, you have an increase in cortisol. That's fine short term, but then it should revert back to the normal level. But if you are in that situation long enough, your normal cortisol curve will stay in that high stress level, even if the stress has been removed. So this is what we are trying to avoid. This is what we're trying to detect, and this is what we're trying to avoid. Now, this is very personal. This is a 59-year-old. She was 59 at this time. This is actually my sister, who's married to my brother-in-law, and she was complaining of insomnia, obsessive compulsive disorder, anxiety, depression, crying spells, inability to concentrate, unable to handle the smallest stress. So when your cortisol curve is that high, it can't get any higher. So when you have a stress, it can't increase. Now, the reason why she was why she was like this is that her husband had a detached retina approximately 2 years before this, and he had a very difficult recovery period. He couldn't sleep because his eye was hurting and itching. I guess it was the healing from surgery. And then during that time, his other retina detached. So for about a year, he was really pretty much blind, and they don't have any children, so she was a primary caretaker for the both of them. And during that time, they both got this awful flu that lasted forever. It was just a horrible year or so. Well, her husband recovered and was doing well, but then she became like this, even though the stress was gone. And what happened, she was placed on antipsychotics and antidepressants. She began stuttering, unable to complete thoughts. Doctor was questioning her education level. She and my brother-in-law both finished Vanderbilt like I did, so my sister was not stupid or retarded, but what she was having was psychomotor retardation from the drugs that the doctor had put her on. So my brother-in-law got very angry, and actually what happened, I make a long story short, my sister who lives, she was driving down here to see my mother at that time, and my sister, who she was staying with, noticed that something was wrong. And so they called me, and I called my sister, and I could hardly understand what she was saying. She was stuttering so much, she couldn't get thoughts out. And I asked her if she could possibly collect her saliva over the course of one day. I told my brother-in-law to help her. And she finally got that done. And this is what we saw. So what we used was phosphorylated serine. When we talk about how to identify and treat stress, you'll understand that phosphorylated serine helps to kind of reboot the cortisol curve. It helps your brain to understand that that is not the normal curve. We use some supplements with 5-HTP in it to increase serotonin and other amino acids and adaptogens to help normalize that cortisol curve. And after 2 months, all of her symptoms have had resolved. So this is a very personal patient, personal situation here. And if she had not been my sister or gone to a doctor who understands this, she would have been on disability on Medicare. And this is actually about 6 or 7 years ago. So you can just imagine what their relationship would have been like if she had have continued to be in this situation. Now, this is 6 months later. Now you see that she's recovering, but you see her cortisol curve is below normal. She's still, what happens is that when you get it, when you treat it, a lot of times it will overcompensate because it needs to recover. And that's what she was doing. I was continuing to give her adrenal support, but she feels like her old self. They're both semi-retired, so they don't do a lot, so they don't require much of the, of much energy level. But this is years ago. She's been fine since then, but this is just an example of how you can help people. So again, she was on the wrong side of this curve, and that's what you want to avoid. Now, most people, instead of their symptoms resolving in a couple of months, they're usually put on this long road of antidepressants. And you see, if you look here, there's really no off-ramps to this road. It just gets longer and longer, and there's some sidetracks, but there's really no way to get off, because once you start this antidepressant journey, it's usually very hard to stop it. And you see it says less exit before toll. And you're going to pay a toll if you continue down this road, and we'll see why. So all stressors increase the sympathetic nervous system. And with the sympathetic nervous system, you're going to increase epinephrine and norepinephrine. And if you increase epinephrine and norepinephrine, you're going to increase anxiety. And when you have an imbalance of adrenaline to serotonin, it's not a Zoloft deficiency. It's because you're making your sympathetic nervous system is creating so much adrenaline, epinephrine, and norepinephrine. And if it doesn't have enough supply of amino acids to make serotonin, dopamine, and GABA, which are more calming neurotransmitters, your body's number one goal is survival. So it's going to preferentially feed the sympathetic nervous system, even if it has to rob the parasympathetic nervous system or the non-excitatory neurotransmitter production in order to make sure you have enough adrenaline. And so if you have too much adrenaline and not enough serotonin, you're going to have anxiety, and then the anxiety is going to lead to depression. So that's why those two are always married. Now, patients are put on serotonin reuptake inhibitors. And what they do is what's supposed to happen is you have these vesicles of 5-hydroxytryptamine and serotonin. And what should happen is that serotonin should be released, and it should be taken back up. It should be almost like a neon sign saying, be happy, be happy, be happy. So it should release it, and then it should reuptake it. Now, what happens is, I told you, is that when you're under stress, you will decrease the amount of serotonin made in favor of adrenaline. And so now what happens is, with the serotonin reuptake inhibitor, because the serotonin level is low, it's trying to slow down that neon sign. It's trying to make the serotonin last longer. So it releases it, and it inhibits the uptake so that the low amount of serotonin will last longer, and it will stay on the receptor longer because you don't have as much to be able to have a flashing neon sign. Now, this in the long run is detrimental in two ways. One is that the longer the serotonin is in the synapse, that's an open space, then monoamine oxidase, and you know those monoamine oxidase inhibitors we have treated in the past for depression, you inhibited the monoamine oxidase so it would not destroy the serotonin. And so if they're not on a monoamine oxidase inhibitor, then that serotonin that's in the synapse is open for degradation. So if you leave it out there longer, your serotonin level is going to get lower with time. And also, the longer the serotonin is on the serotonin receptor, over time, it will desensitize the receptor. Most antidepressants become less effective over time because of those two. The serotonin level is getting lower because it's being degraded, and the serotonin receptor is being less sensitive. That's why it's almost impossible to get these patients off of antidepressants after they have been on them for a long time. And that's why you also have these new drugs to add on to a past antidepressant, because we know that for these two reasons that the antidepressant is not going to be very effective long term. Because in order for your mood to be normal, you have to have a balance of all of these neurotransmitters, norepinephrine and epinephrine. You see it's alertness, concentration, and energy. But when they're all together, you see everything works right. Your anxiety is okay, impulsivity is normal, irritability is normal, mood and cognitive function is normal when all of these neurotransmitters are in the proper balance. But under stress, you're going to shift this toward the norepinephrine and epinephrine and away from serotonin and dopamine.